dear moderators and dear colleagues. My name is Christian Bogdan. I'm Trust Registrar in a Thoracic Surgery in St. James Hospital in Leeds. Thank you very much for giving me the chance to present the results of our study. It was a collaboration between a Thoracic Surgery Department from Leeds and a Respiratory and Oncology Department from Airedale Hospital, one of our district hospitals. Basically, we all know that the long-term survival for lung cancer is poor. And of course, one approach to improve the treatment and the survival of this patient is to try to increase the resection rate. It's a national recommendation that all the patients should be discussed in the NDT meeting, and during the NDT meeting, a surgeon should be present. Unfortunately, not all the time this can happen. So we aim to assess the impact of surgical presence in MDT regarding the referral for surgery in one of our local hospitals that previously didn't have a regular surgical presence in their meetings. As a method, we prospectively collected the data of all the patients discussed in the lung NDT meeting in 2011, overall of 12 months, and we compared it with the number of the patients discussed on the year previously, again for 12 months. There was an NDT meeting every week, but in the first year, in 2010, only selected patients were discussed with a surgeon during a separate meetings. In 2011, the second year, all the patients were discussed in the presence of the surgeon. As a result, in 2010, we have 594 patients discussed in total, and from these 109 cases were discussed, selected again, with a surgeon. In total, in 2010, was 60 operations. In 2011, having a surgeon present, there were 704 cases discussed, and in total were 108 operations. We can see from the two tables that compared on the 2010 and 2011, there was no real difference between the age of the patient discussed in total compared with the age of the patient that had an operations. So maybe we're not very aggressive regarding that. The same repartitions, a different way of showing. Now, breaking down regarding the type of the operations, we can see that overall there was an increase in all types of procedure except mediastinoscopy and lung biopsy, probably for mediastinoscopy because now a lot of these are done EBUS, and they're doing a very good job, maybe, I'm not sure. But we can see especially that the number of the lobectomy increased from 17 to 31. We have in 2011 2 pneumonectomies, and we have wedge resection from 4 going to 9. Again, breaking down regarding the type of the procedure, we have an increase overall of the diagnostic, curative, and combined diagnostic palliative procedures with maintaining the same proportions. From histology point of view, regarding the benignity and malignancy of the procedure, again, is an increase, again, the same proportions. Now, regarding the histology of lung resection, and probably this is what is most important for us, we can see that for non-small cell lung cancer, there was an increase of the anatomical lung resection from a lobectomy point of view from 13 went to 19, and we have 2 pneumonectomies, and the number of the wedge resection for non-small cell, it's even less. Breaking down on the stage, we can see that, at the first, maybe we can think that we are more aggressive and we start to operate maybe more advanced disease. And it is not really true. Indeed, we have 3 patients with stage 3 that had an operation in 2011, but at the same time, we can see that in early stage 1B went from 8 cases to 15 cases operated. Again, trying to see the demographic, and from age point of view, again, I cannot see that we became more aggressive in 2011. The median age for anatomical lung resection is 71 on both years. And of course, we try to see, okay, we are doing a lot more operation, but are we changing the resection rates or not? We have to go back and look at the data and to take the number of the patients that have diagnostic of non-small cell lung cancer to be able to calculate our resection rate. In 2010, we have a 15.3 resection rate. In 2011, 24.1. Again, on this year meeting on BTOG, the Lucada presented the 2011 results, and we can see that it is an increase of 1.5% overall at the national resection rate from 13.7 to 15.3. And also overall at the network and trust, of course, we have the trust rejection rate in 2011 between 0 and 100, but this is mostly because some of the trusts have a very small number of the patient, easy to obtain this kind of percentage. What is very strange is that Airedale presented as a rejection rate in the Lucada 12.1 in both years. Basically, they were the only trust to have the same number of non-small cell lung cancer and the same number of the operation both years. That is a little strange, but this is data anyway. And as a result, we can see that we have an increase of 80% in the patient having surgery. We have a 61.5% increase in the number of anatomical lung resection for non-small cell lung cancer and 82% for any histology. And of course, this is on the background of 90% increase in editing meeting activity. In conclusion, we proved that the surgeon present at NDT meeting has increased the number of the patients who were referred for surgery. And of course, this supports the national recommendation that the thoracic surgeon should attend all the NDT meetings. I'm not sure if this is possible everywhere. In this moment, it's too early, unfortunately, to comment on the impact that this result will have on the long-term survival, because maybe we can think that maybe we are more aggressive and the survival is the same, but we have to see. And again, we have to be sure that the lookout data is the right one. I mean, they are aware that there are some problems with how the data are acquired, and our results, unfortunately, prove that it's not somewhere is a problem. Thank you very much.